field and where I'm at now. So let me share the screen. And all right. So my name is Jamie Bolduc. I'm a family medicine physician specializing in aesthetic medicine as well. I'll talk a little bit more about that field and how I got into aesthetics, but what I'm going to talk about today is dizziness. So this is something that's pretty common in family medicine. It's something that you're going to see a lot of, and there we go. Okay. And to be honest, a lot of us don't really like seeing these type of patients because dizziness is a very non-specific symptom. It can be attributed to a lot of things, which makes it hard to sometimes diagnose and treat. But you're going to have people that come in with this symptom a lot. So I figured we'd have a quick little overview of how you can go about working it up and treating it. As a pre-med and before you even get into the medical career, it's good to know how to approach patients in general. So I guess my advice to you would be whenever you have a patient that you're dealing with, you know, always obviously pay attention to what they're coming in complaining of. And the way you want to approach it is you want to ask them pertinent questions. So what is going to help you diagnose them? So any pertinent positive or negatives, you know, you do your exam, and then towards the end of the interview, you should have a better idea of working and what okay.
Dr. Bolduc, I think that the connection is. Dr. Bolduc, can you hear us?
Get a feel for what you think is important. You want to rule out the most life-threatening things, of course. And towards the end of your interview with any patient, you should have a better understanding of what you're going to order or not order. So that's kind of what you should keep in mind every time you see a patient. All right, so dizziness, the most common cause that you're going to have when the patient comes in complaining of dizziness is going to be peripheral cause. And that's about 40% of the patients that you see. There's peripheral versus central causes. And in a little bit, I'll differentiate the one from the other, but just to get a common knowledge. And then in those patients that do complain of dizziness, about 10% of them, we really don't know what's going on. So that's where the frustration comes in with this complaint. And then as you start getting into age ranges, the older adults are going to have more common cause being related to central causes, such as a stroke. All right, so central versus peripheral. When you think of central, for me, it comes natural to think more of the central nervous system in the brain, and that's typically what it's related to. And when you have peripheral causes, then it'd be related to the inner ear, the vestibular nerve, and are made even worse by COVID-19. Okay, the nucleus in the medulla, and then some connections in the cerebellum. So when the patient comes complaining of dizziness, you're going to start thinking of different causes. It can be due to presyncope, it can be due to even psychiatric causes, vertigo, tumors, just change in blood pressure. The differential is very vast. And the word that is going to be very much associated to dizziness is vertigo. Vertigo is pretty much when you think of the room spinning around. And that's what you're going to even ask the patient sometimes. And vertigo can be due to peripheral or central causes, but it's typically more likely related to peripheral causes. So like I mentioned before, the first thing you want to do is you get your HPI, which is you get the basic information, how long has this been going on, what makes it better or worse, and all these questions are going to help you differentiate between the central and peripheral causes. And it's important to know which one between the two it is, because the management for both of them does vary a lot. Okay, and then I have a little chart here just to give you an idea of what you can think is peripheral and central. So peripheral, you're going to think more the inner ear. So you have a Meniere's disease, vestibular neuritis, even herpes zoster. The most common for peripheral is Bppv, benign paroxysmal positional vertigo. You also think acoustic neuroma and even otitis media. For central causes, you think more central nervous system in the brain, so tumor in the brain, the brainstem ischemia, vestibular migraine, and even infarcted or hemorrhagic stroke. So you can see the differences between the two. Now it's just figuring out which one's which, right? So you have your patient, they come in complaining of dizziness. You're gonna ask them if they feel like the room is spinning. So vertigo is like the first thing you wanna differentiate. And then you wanna ask them how long it's been going on. Is it been, does it last seconds? Is it for months? Has it been going on for years? Typically, this isn't the final say, but it's a good guide to go by. If they last for months, more than likely it's not going to be vestibular, it's going to be more central, because the central nervous system tends to have a way to adapt to the defects in the body. If you have dizziness that is only one time and it lasts only several minutes, you want to think of a stroke or more like a TIA, or sometimes even a migraine. Now, the symptoms keep coming back, you want to think more Meniere disease. And Meniere's disease is a triad, so it's dizziness, tinnitus, which is ringing in the ear, and hearing loss. And then if you have dizziness that's acute, comes out all of a sudden, and it lasts a few days, you want to think more vestibular neuritis, which is more of a peripheral cause. And then next thing you want to ask is, what makes it better or worse? Does changing positions make it better? Does it make it worse? Anything that causes pressure in the middle ear, like sneezing, coughing, doing the Valsalva, all these things are going to help you make the differential. And I made this little chart. It's not all inclusive, but it's a very good guide to guide you more to thinking one versus the other. So talking about central, more than likely, nausea and vomiting is not very common. It could be, but typically not. The onset of the symptoms is very slow. It tends to be constant. It's not related to positional at all. Now, nystagmus. Nystagmus is going to be present in both central and peripheral, but the direction of the nystagmus is going to help you differentiate one from the other. So vertical nystagmus is more related to central. And then another thing related to central is that the symptoms typically don't go away. So let's think in this case, the patient is having dizziness and we're thinking it's central. And in this case, it's a tumor. The tumor, it doesn't matter if you take Tylenol, if you take anything, that tumor is there compressing in the brain, and that those symptoms that you're having, that the dizziness, nothing really is going to make it go away. And that's one way that you can think of it. For peripheral causes, nausea and vomiting is very common. The symptom tends to be very sudden and intense, and it comes and goes. It is related, it can be related to the change in position of the body. And then as far as nystagmus, instead of being vertical, the horizontal nystagmus is the more related to the peripheral cause. And symptoms tend to go away with medical management. So think of if you're in a boat and you're having the nausea and the dizziness, those things, if you take certain medications, can help it go away. Other things that you want to ask are symptoms that may be associated. So look at the patient's gait. Are they able to walk? Do they need to hold on to the wall? Or are they going to fall over if they're just standing? Are they having any numbness or weakness? Any double vision? Any headaches? Any neck pain? Do they have ringing in the ear? Have they had any recent cold? Any fever, sore throat, or cough? Now, we went through the HPI, we asked them all these questions, now we go into the physical exam. So you are a little bit limited in the physical exam because there's not too much that you can guide yourself with, but there are some little tips that can guide you more towards one than the other, and I put the most important ones here on this slide. When you're doing the head exam, like I said, the nystagmus, you can differentiate central versus peripheral. For nystagmus, it's basically looking at the eyes and seeing what direction they're moving, if it's more horizontal, more vertical. And then for neurological, look at the patient. Are they able to stand by themselves, or are they going to tip over more to one side? Or can they walk straight? And the Romberg test is the one where you have the patient standing up straight, kind of tell them to close their eyes, and then you notice their balance. Look for central nervous system abnormalities, any changes in their motor or sensory. What about the reflexes? Is it abnormal? One specific exam that you can do is the Dix-Hallpike maneuver. This is most common one to diagnose Bppv, which is a benign paroxysmal positional vertigo. And what this does is pretty much you have your patient laying down on the bed. You have them lay down with their head a little bit off of the bed, and you quickly turn it to one side and then turn their head to the other side. If this elicits dizziness, that's positive, and it's positive specifically for Bppv. And while doing that maneuver, you can also see if it elicits the nystagmus. So this test is very helpful. It's very easy to do also. And what you see there is that it tests for cannulas. So those are little stones in your inner ear. We'll talk a little bit more about that. And then as part of your physical exam, if you're thinking that it's related to blood pressure changes, if the patient says, for example, I feel really dizzy when I get up from bed, or if I'm sitting down and I get up really fast, then you want to think maybe orthostatic blood pressure. So you want to get their blood pressure from when they're laying down to sitting, from their sitting to standing, and see if that blood pressure changes. If it does, then you want to think more towards that route. Other exam that you can do is called the HINTS exam. This is only something that you do if the patient is actively having symptoms. If not, it's not very accurate. And I put a picture over there that you can see as part of the exam. So HINTS, it stands for head impulse, nystagmus, and test of skew. So for the head impulse, what you want to do, if you look at the image over there, you get the patient's head and you tell them to fixate on an object, and then you turn their head from one side to the other, and their eyes should still be fixated on the object. If it's not fixated on the object, then that's a positive test and it's more indicative of a central cause. Nystagmus we talked about, just look if it's horizontal or vertical. Then I'm going to go to the next slide, which goes a little bit more into the HINTS exam. And the test of skew is pretty simple. You cover one eye, have the patient look forward. When you take the hand out from covering the eye, the patient should have the eyes looking straight forward. If it's not, if it's more to one side or the other, that's also indicative of a central cause. So that's the HINTS exam. And then, so getting to diagnosis. So we have the patient, we talked to them, we did the physical exam, we have a better idea of whether we're thinking more central versus positive. So now what? So let's say you have a HINTS exam that's positive. We said that that's more indicative of a central cause. We looked at the nystagmus, and this is just a little overview again. Horizontal is more peripheral, and the vertical nystagmus is more central. So if you're thinking more central cause, you want to do imaging of the brain because you want to see if there's anything there. So if you're thinking of a schwannoma, of any type of tumor, you're going to get an MRI, and that's typically with contrast because we know tumors have the blood flow through them. So that's the reason for the contrast, okay? Treatment. So the treatment between these two is very, very different. Peripheral, typically you can manage it with medications. If the patient is in the hospital, you can discharge them, or if they're in your office, you know, they can safely go home. Medications that you can use are antihistamines like meclizine, and that's going to treat not only the dizziness, but the nausea and vomiting associated with it. Other medications you can use are antiemetics, or medications that help with the dizziness. So you have Zofran, which is also ondansetron. You have Reglan, which is metoclopramide, and Phenergan, which is promethazine. So they're the big three. And then for Bppv specifically, which we use the Dix-Hallpike to diagnose, Eppley Maneuver is the treatment for that. I think in the next slide, I have a picture of how you do that. But typically for my patients, if I diagnose them with Bppv, I'll print them out a picture of how to do the Eppley Maneuver. And typically that's enough and it goes away. So it's pretty effective. Treatment for central. So this one, if you think the patient is having a central cause, if you're in the office, you tell them to go to the ER because they need to get admitted. If they're in the hospital, you just admit them. You want to do a stroke workup because you never know, that could be the cause. So you want to do imaging of the brain like we talked about earlier, and then you're going to get neurology to come and see them. Okay, and that's going to, and then, you know, from there it's more workup, but that's more, you know, more detailed. So Eppley Maneuver. So if you follow the letters, there's A, B, C, and D. So you're the patient by themselves while they're right before bed, and they'll typically do this about 3 times before going to bed. They're gonna lay down, turn their head to one side, then turn it to the other side, and then that last side that they turn it to, they're gonna turn their whole body towards that. And what that does is it repositions the little stones in the ear to go to another place pretty much, so that that dizziness goes away. And that's really the treatment. It seems pretty simple, but it's very effective. All right, let's see. Okay, and this is just some references. So that was a quick overview of just dizziness. Like I said, it's a very simplified version because there's a lot of components that go into it, especially if you go into the central cause of it, and then you have to bring the specialist and it's imaging and a lot of stuff. Peripheral is the more straightforward one to treat, but the hard part is being able to differentiate and getting the accurate information for it. So now I'm just gonna go a little bit over my background. So I went to undergrad in FIU. I was lucky enough to stay in Miami for almost all of my training. So from FIU, I went to Nova for medical school, which is maybe about an hour from where I live. And then residency, I'm in my last year now. It should be done by July, so time goes by quick. But I also got to do my residency in South Florida, so I was lucky to stay close to family and stay in sunny Miami. So now I'm actively looking for a job in medicine. I have the aesthetics thing going on, but I'll get into that in a second. So just little tidbits for, I know you guys have a while to go, but things that you always want to watch out for when you're looking for a job, or just even in your training to be aware of, is when you have your clinic and you have to see your patients, you always want to take note of how many patients you're seeing and how many hours you're working. Because once you start looking for jobs, you want to enjoy what you're doing. So you don't want to be overwhelmed with having so many patients and being crunched on time. So you're focused on seeing all the patients that you're not giving them accurate care. And that's a big thing in family medicine, because most of us end up going in outpatient clinics. So that is a biggie. And you can also go into the hospital. So it depends. And then another thing that you want to focus on is, if you do want to work in an outpatient, the place that you're working at, are they going to make you work in a hospital as well, or is it solely outpatient? Always ask about on-call schedule. I personally don't like being on call. Sometimes it's part of the job, but there's a lot of jobs out there that it's not necessary to be on call. For most doctors, you do have to relocate for work, due to better opportunities where you want to end up staying. And jobs will offer compensation for relocating for you and the family. Loan forgiveness. Medicine is very expensive. There's no way around it, so it's not even something you should worry about if you want to go into medicine. It comes with the game. But always think about, if your residency is part of a loan forgiveness program, if you want to continue with that program, and if you don't, maybe the job that you end up getting gives you loan forgiveness. Paid CME, so once you get your license, you have to continue to get courses to keep your license. So those are things that you want to keep in mind. Is malpractice insurance offered? That's a kind of a biggie, because especially down here in Miami, a lot of people like to sue, so you want to have your butt covered. And then vacation time and sick days. These are things you should all ask for. As far as salary and vacation time, I would wait more until you're later on in the interview process to ask about those things, because you don't want people to think that that's your main focus, because it's not. It's more, making sure you're fit for the job, and then you talk about that stuff later on. So as far as I go, like I said, I'm in my last year of residency. I'll be done officially in July. In the last few months, I would say I kind of dabbled with aesthetic medicine. I got lucky enough to shadow family medicine doctors that also do aesthetics. They do a little bit more surgical aesthetics, which isn't what I would like to do, but I still got introduced to the world of it. So I got to see a little bit of procedures, do procedures myself. So I kind of just decided to jump the gun and open up my own company. It's called Bold Beauty Bar, and there's information. And if you guys have any questions about aesthetic or anything in general, you can go to that Instagram page, and it has also my personal page. Don't hesitate to contact me or ask me any questions. I'm always friendly, and I respond pretty quickly. So I decided to open up my aesthetic company right now, especially because of COVID. Most of the services that I'm giving are at home, so I'll go to their house and provide these services from them. So for those of you that don't know what aesthetics is, it's pretty much giving medical grade services to the patients. And what does that mean? It means that only medical professionals, people with a medical background can do these things. So it's either an MD or DO, a PA or ARMP. So it's not like going to the spa and getting a facial. Those are estheticians. It's very different because here we'll do Botox, we'll do microneedling. So you're giving medications essentially to the patients, and it's a little bit more invasive. What draw me to aesthetics is the fact that these are procedures that you're doing. In family medicine, depending on where you train, you don't typically do too many procedures unless you're in a more rural area and you're the go-to doctor for everything. But down here, there's not too many procedures, and that's something that I personally like. So I decided to kind of take it into my own hands, and that's the reason that I got into it. And it's also mostly cash only business. So that's also a nice thing because we do have our bills to pay, and residency, you don't get paid too much. So you got to keep all these things in mind. But some procedures that we do in aesthetics is Botox, microneedling, fillers, sclerotherapy, Kybella, which is a substance that actually burns fat, laser treatments, all these things, which are pretty awesome. And I believe that's it. I don't know if anyone has any questions, anything, comments, you can ask away.
Yes, thank you so much. There's tons of questions in the chat, some of which you kind of already answered, so we can go through that. One question that we got was, how much research did you do, or what specific reason did you choose to pursue DO instead of MD?
So I research as far as MD or DO, being completely honest with you, I'm the first one in my family to be in medicine. I didn't really have anyone guiding me or telling me you should do this or you should do that. I kind of learned as I went. The reason I did DO is because I got into Nova and I just decided to go for it. Even I wouldn't say I was the smartest in the way I did things because I didn't apply to like 20 schools. I kind of did like 2 or 3, and I got lucky that I got into like 1 or 2, and I just went there. At the end of it, now that I'm finishing my residency, there really is no difference between MD and DO. The patients don't know. You practice the same exact thing. The only thing is DO, you do extra is the manipulative treatments, which I myself don't ever use in training, and I know most of my DO fellows also don't use it. So I know that some people may have the bias, but medicine is changing now. I know that they're trying to merge the exams and make it more uniform to everyone. I would say if you want to be a doctor, I mean, they're both equally great, and you shouldn't discriminate one from the other.
We absolutely agree.
Sorry, I had a question. So do you think, I know that it doesn't matter between the two, MD versus DO, but do you think in terms of getting our shadowing hours, do you think med schools would discriminate? Like if for example, if I'm applying for a DO school and being that we have limited shadowing opportunities right now, or we can only like get it virtually, do you think they would not accept the hours done like shadowing the MDs, or do you think they would be as lenient with that or no?
I don't think they would care whether you shadow an MD or DO, because at the end of the day, they're already physicians, more than likely board certified. So I don't think if they do discriminate on that, I would say that's more of an issue, and that's probably somewhere where you don't want to be. But I personally don't think that should be an issue at all.
Thank you.
Mm-hmm.
Okay, great. Thank you so much for that. So we had some questions just kind of asking about how COVID has impacted your residency and starting your company and all that, and if you've had to really incorporate telemedicine at all.
Yeah, so for my residency, it's impacted us quite a bit. We've had some rotations that were completely canceled, so the residency program had to scramble last minute to find other places, or kind of conform and change the rotation completely. And then as far as clinic, we do telemedicine, and I still try to keep most of my patients telemedicine because COVID is still rampant. And then with the strain and everything, especially down in Miami, it is pretty crazy. So for my patient safety, if they don't need to come in person, I try to schedule everything telemedicine. But yeah, COVID has changed things dramatically, which is part of the reason that you guys are on here now. But I mean, you find a way around it, but it does make things a little difficult.
Yeah, absolutely. Well, thank you for, doing your part.
Mhm.
We had a question kind of more specifically about aesthetic medicine,
Okay.
and it was, how does Botox affect sweat glands? It could be, used to treat, preview sweating. So is there any negative effects to that or anything like that?
So I've actually had at least 2 clients that I've treated for that. So it's called hyperhidrosis, and you have excess sweating. And the main locations to treat that is in the hands, in the feet, or the underarms. And typically what it does, Botox is a neurotoxin. It's basically a toxin that you're injecting into the system, and it comes from a bacteria. And what it does, when you're thinking in the grand scheme of things, essentially what it does is it's paralyzing the muscles. When you inject it for hyperhidrosis, you're injecting very superficially. So what it does, it stops the sweat glands from producing sweat, and that's the whole purpose that we use it. And even when you use it in the face for wrinkles, because that's typically the main reason is to prevent wrinkles. Even when you do that, it does help overall with the texture of your skin and oil production.
Great, thank you so much.
Mm-hmm.
So we asked about that. So what are, a lot of people wanted to know, what are your favorite procedures to perform?
I think the one I do the most and the one I actually love the most is Botox, because every patient is different. Like, not one person here is going to have the same exact treatment. And when people ask, oh, well, how many units does Botox do you usually need? I can't answer that because it depends on you. Guys tend to need more than girls because their facial muscles are stronger. Maybe your lines are deeper than hers and you might need more. So that's why it's nice, because it's like a little puzzle, and you get to you thinking every single time you do it.
Great, thank you so much.
Mm-hmm.
There are a lot of questions that are just asking why specifically you chose to go into family medicine. I know you kind of touched on it a little bit.
Mm-hmm. So initially, I actually wanted to do emergency medicine. I used to work as a scribe in the hospital prior to doing medical school, and I believe it was like 2 years that I did that, and I really liked the environment. I loved that it's fast-paced, and it was just a fun environment to be in. Once I got into medical school and I started going through the different rotations, you kind of get a feel for some of the rotations. ER is one of the main ones that you do go through, and it is fun, but in the long term, it's tiring, and you do burn out a lot. I think if it's not the top, it's one of the top fields where you do have the highest burnout rates. And for me personally, as a female, I would, eventually want to have a family. I don't want to be tired or be worried overtime and like not be able to see my family as much, or when I do have time to see them, I'm beat. So I decided family medicine because it's of a more laid back field. You see a little bit of everything. I mean, you have to have a little bit of knowledge of everything because we're general practitioners. We see from kids, if you want to, you don't really have to adults. So you have to have a little bit of knowledge on everything. And you build a rapport with your patients, which is nice. They talk to you about their family, you get close to them, you end up seeing their family. So it's nice.
Great, thank you for answering that. Could you explain, because I know a lot of people have this problem with distincting, the difference between family medicines versus internal medicines, and is family medicine considered primary care for a lot of people?
So family medicine is considered primary care. Internal medicine doctors can be primary care doctors, but the biggest difference is really in the training. Ooh, and I'm sorry for that, it's my dog. But the biggest difference really is in your training. If you're thinking you want to get into GI, or you want to be a pulmonologist in those subfields like anything like that, you want to start thinking internal medicine, because family medicine is open to a lot of fields, but not like that. For family medicine, once you do your training, you can do fellowships in OB, sometimes even ER, but gastroenterology, pulmonology, ID, infectious disease, stuff like that, you need to go through the internal medicine field. As far as residency training in itself, internal medicine, you're mostly in the hospital seeing adults, don't really see peds at all. For family medicine, you're in hospitals and in clinics, in outpatient centers, in private offices, and you see peds, you see everything.
Perfect. Thank you for helping us to sync those. So there was a really interesting question saying, you know, the competition for aesthetic procedures right now in this industry is so, you know, vast because, you know, we have aesthetic medicine, we have dermatology, we have facial plastic surgeons, and a lot of them do, you know, similar procedures. Knowing that, and then also knowing that there's also PAs and NPs that also are doing these procedures and injectables, how do you stay competitive?
So I'm just starting off, so I wouldn't say that I'm straight up competitive, but just from what I've heard from my own patients and just from colleagues is, especially being in Miami, I mean, that's like the epicenter for aesthetics, and a lot of people are into their image. So it is a great place to go into the field, but it is competitive. So the one thing that I try to distinguish myself from is I go to their homes and give them the procedures, which now in the COVID era is great because people don't want to go out. They're scared to go out in public. They don't, and in Miami traffic, they don't even want to deal with that. So that's one thing. Another thing is I am the one that does the procedures. If you go even to a dermatologist office for Botox, typically the nurse practitioner or the PA will do it. And just from what I hear, a lot of people don't like that. They go to the doctor's office because they want the doctor to perform those procedures. So I feel like it's more of a personal touch that I'm the doctor and I'm the one that's doing the procedures.
Great, thank you so much. So a few asked about the location of medical school and how that affects, you know, residency, or how important that is for setting up your life post-residency.
So for medical school, I was in the library like 99% of the time. So, I mean, I was close to home, but it's not like I could come and visit all the time because you're busy studying. You have a test, at least one test every week. So, I mean, yeah, it's good to like where you're gonna be, but is that really what should be your final decision on, you know, if you're gonna go to med school or not? Probably not. I don't think the location makes a huge difference. I mean, everyone is different. Like if you like a sunny area, or if you know you don't like snow, you're more than likely not going to want to go there. And then as far like as residency with location, you do have more time to go out and explore. I've had some colleagues that hate Miami, and as soon as they were done with residency, they went back home. And I've had people that love it here and ended up staying here because of their experience in residency. But it's hard for me to say because it's based on the individual and what kind of environment you like. I would say for residency, you know, try to find a place that you do like, because that's where you have more free time to explore and go out, and you're there for like at least 3 years. So it's a good chunk of your life. But it also shouldn't keep you from going somewhere, because at the end of it, if you don't like the place, you can always leave once you do finish residency and find your permanent job.
Thank you. So can you speak a little bit more on the loan forgiveness and what that looks like? You emphasize that medicine is really expensive. The payoff is obviously wonderful, and your impact on the world is super rewarding, but can you go into more detail about that and what that looks like and how to look for it and so forth?
Of course. So there are different programs for loan forgiveness. The one that I'm personally in is a public service loan forgiveness. And you should, when you go into your residency, always ask if they're part of those programs, because if they are, that's automatically 3 years that are going into the loan forgiveness program. The one I'm in personally, it's if you are working for a program that applies for that, it has to be a total of 10 years. And then at the end of the 10 years, supposedly whatever you don't have, you pay every month you're supposed to pay, and it's income-based payment. So it's not like an outstanding amount that you need to pay, but you do need to pay a certain amount every month. And then at the end of those 10 years, whatever's left over, from what we hear, it's supposed to all be forgiven. The only caveat to that is, okay, let's say you're in a residency program that is part of that. Okay, you have 3 or 4 years that go into that. And then now when you graduate, you need to decide, am I going to get a job that is still part of that program, or am I going to venture out and find something that isn't part of the program and just try to pay the loan off quicker myself? And the reason that that's such a big deal is because typically the places that are part of the loan forgiveness program don't pay as much. So you have to weigh the pros and cons. Do you want to be in a place where you're not going to get paid as much and typically end up working a lot more and seeing a higher volume of patients for a completion of 10 years? Or are you going to sacrifice that, go to a job that pays a lot more? You're going to see less volume, and because you're getting paid a lot more, you can put more every month towards your loan and pay it off quicker. So that's kind of where I'm at now. At the beginning of residency, I'm like, oh no, I'm just going to stick with the program and get the 10 years and it'll be done, because I went to Nova and that's a pretty expensive school, so I have a lot of loans. But now that I'm looking for jobs, I'm like, that's ridiculous. I'm going to be tied down to a place that I probably don't want to go to. I'm going to be overworked. I'd rather get a place that I enjoy, that I'm going to get paid more, and then just pay off the loan that way.
Thank you. I think that's a huge topic that isn't discussed frequently, and definitely impacts, the route of a physician and this journey for sure. So could you maybe talk a little bit about like what aspects of healthcare that drew you into becoming a physician? Like what made you decide this was what you wanted to do? And yeah.
So I'm sorry, just to reiterate, you were asking, you cut off for a second, what made me go into the field?
Yeah, what made you decide to even become a physician before even, declaring your what you want to be? Yeah.
So initially, I decided to go into medicine, or was dabbling with the idea of it because I just like biology. Straight up in high school, I'm like, oh, I really love biology. And then going into undergrad, I'm like, oh, well, you need to figure out what you're going to study with. So I'm like, let me major in biology. I love science, so I got into it from that. And then typically everyone well, not everyone, but like most of the people that major in biology are doing the pre-med route. So just meeting people through there and joining pre-med clubs because of that. And then doing community service, and you're kind of just subjected to that world. That's what opened up my eyes to medicine. And I got to do community service. I shadowed doctors. I love the idea of like not only knowing science, but combining that with the medicine world and helping people out. And that's really what got me into medicine. So it was more the introduction into the sciences, and then getting the experience doing the community service that you see, like, man, I really enjoy helping people and seeing the difference that you can make.
So throughout your journey, how did you reach out to people to like shadow, to volunteer, and to even possible research opportunities? Right now, it's definitely different for all of us going through COVID as a pre-med, but when we return to some normalcy, how do you suggest a pre-med reaches out for these types of opportunities?
So it is a lot of hustling, and even now that I'm just starting to get into the aesthetic world, I feel like I'm kind of around that playing field where I'm like, oh, I need to find doctors that are going to let me inject their patients, and that I can shadow them and learn their techniques. But it really is a lot of hustling. Like as a pre-med, I honestly would go online, reach out to doctors around the area, email them or call the office and ask them just if I could shadow them. For pre-med, I've seen that it is easier for them to be like, yeah, you can come shadow me here and there. And it typically wasn't a problem for me. I don't know. I'm sure with COVID now it's a lot more restricted, and they don't want to risk you guys getting sick because of that. But it's really just reaching out and talking to people and making those connections, because in medicine that really goes a long way. It is a lot about who you know, and who you're going to get to know. So always have the best face forward, be nice to everyone, because you never know. Medicine is a small world. People do talk and know each other. But yeah, you always do have to hustle and reach out, and don't be embarrassed or ashamed to reach out. Even if they say no, whatever. They said no, just try the next person.
Thank you.
Mm-hmm.
So family medicine, how often do family medicine physicians work in a hospital, and what is their role in a hospital setting?
Mm-hmm.
You go ahead.
So that depends. In residency, you have to rotate through a hospital because you have to get exposed to a little bit of everything. But most of our rotations are outside. And then once you finish residency, it really depends on what you want to do. You have the choice. If you want to work solely in a hospital as a family doctor, you can. If you want to work solely in outpatient, you can. And then there's a mixture of both. So it really depends on what you want and what you feel comfortable with. You're not going to be forced to ever do one or the other.
So can you clarify, thank you. Can you clarify, so you're in residencies for family medicine, and so as a family medicine doctor, you can practice aesthetic medicine. So how is that going, the business that you have built on the side, how is that going to weave into you practicing as a family practitioner?
So right now, it's hard to give a straight cut answer for that, because I am trying to find, like, I'm in the process of applying for jobs, but that's through the medical field and being a family practitioner. And then in the meantime, even now, I have my company on the side. So if someone calls me right now and they're like, hey, I need Botox tonight, I can go and do that on my own. And that doesn't really tie me down. The only reason I would see that it would tie me down in the future is just scheduling. But once I have my office or I work at an existing office, you can always pitch that to your clients. It's not you're not competing, because I'm providing completely different services. And then some offices might even let you provide those services there. So it's not a clear-cut answer. It really depends. Eventually, I mean, I would like to have my own clinic for the aesthetic company, and even if it's just one room to start off with, and be able to provide those services to my patients in a more professional setting. But right now, and just because of COVID, it's more efficient for me to go to their houses and provide those services there, and it's less of expense to me because I'm already head over with the loans.
Thank you. And so going off of that, do you learn in residency how to inject? Where does that play a role?
For the aesthetics?
Yes.
So no, the whole aesthetics part of it, I pretty much did on my own. I paid for my own courses to do that, which is not very cheap. But with the services that you provide, and like I said earlier, most of these services are cash only. So you'll eventually be able to pay it off, but like, it is something that you have to do on your own. I researched it on my own. I looked at a lot of YouTube videos prior to taking the courses, and then eventually decided to take the courses, purchased them. I got my certification, and getting the training and doing it over and over again, that is the hard part, because in Miami, it is so competitive that, if I ask someone in an office, hey, would you let me shadow you? Their first thought is going to be, well, you're going to be my competition, so why would I let you shadow me? So that's the hard part now. But sometimes you get lucky and you find one or two people that'll help you. I'm still in the process of finding those people, but yeah, when I branch off into aesthetics, that's something that's completely on my own, has nothing to do with my medicine or my residency. I just have it it's like a hobby of mine that I turned into, now my company, and everything that I'm doing, it comes out of my own time and pocket.
And are those certificates via like a hospital or a company, a pharmaceutical company? What does that process look like?
There's a lot of companies that will give you a certificate for that. You need to do the course, now with COVID, it's a little bit here and there because a lot of them weren't doing in person. Now they're starting to transition to doing in-person lectures and training. But you do need to go to the in-person training to get the certificate, obviously. But there's a lot of different companies. I myself did Empire Medical Training. They provide, you can take one course individually, or you can do the membership, and then through their membership, you can take all of the courses that they offer with that one membership price. So that's what I opted for, because I not only want to do Botox, but I want to do other procedures. And just one course for Botox is really expensive. It is actually more economical to do the membership program if you want to end up doing those other courses. So that's the course I took, and I decided on them because I was just comparing prices. And then the doctors that I shadowed, they actually went through their program. So I felt comfortable with them, and I went with them.
Great, thank you so much. Could you say that site one more time? Someone was asking.
Yes, it's Empire Medical Training.
Okay, we'll put that in the chat too. Okay, great. So while we're doing that, someone asked an interesting question, and I probably know the answer to this, but do you see yourself going into dermatology specialization in the future? Is that something that you're not interested in?
No. So I don't think so, because there's overlap between dermatology and aesthetics, but dermatology is a lot more involved. So it's more like if you have a rash or have a little bump here, and that's not really what interests me. It's more doing the procedures and having this patient see instant results. So I don't think I would ever venture into the derm world. I've had a lot of people ask me that, but I actually don't like dermatology. So I don't think so. Just keep it to aesthetics.
I know that had to have hurt Danielle a little bit because she loves dermatology.
It's a great field, but you know, everyone is different.
Yeah. Okay, there's a question that's been asked a few times. Can you a little bit elaborate why someone should go into an Mddo program over a PA or an NP program?
So that depends on, I would say, a little bit of ego and a little bit of, like, you know, what you're able to get into. If you're an MD and DO, you're going to end up being your own boss. You're going to have more autonomy. You're going to be able to do a lot more things and not have someone oversee you. As a PA, ARNP, typically you need to have a doctor sign off your charts, look over you, and you're limited to what you can do. I know that PAs and ARNPs are having a little bit more liberty now with the things that they can do. Training wise though, the training is completely different. You can't compare 4 years of medical school with residency training to the other schooling, where it's like probably half that amount or less than half of the amount of training. The knowledge, the depth of knowledge is very different, and that's why I know a lot of colleagues get mad, you know, when one or the other are compared. It really depends on what you're comfortable with. If you want to be a PA, I mean, I've seen great PAs, and they're probably a lot smarter than some doctors I know, but that also comes with experience. So it really depends what you want to achieve, where you're trying to get at. So that's a hard one to answer.
Yeah, it definitely is. So thank you for, you know, kind of guiding us a little bit. It definitely is a personal choice when it comes down to it. I think we are pretty good on, just kidding. We had questions coming in right then. We've had a lot of discussion in the chat while you've been talking about how important grades are when applying to medical school, and, you know, should you beat yourself up over a couple, like 1 or 2 B's or C's, or, you know, a pass fail here or there, and do you think that there will be a little bit more leniency, as, you know, we're kind of in a pandemic and it's been a crazy time for us?
To apply to medical school, I would say grades are important. I wouldn't take the pandemic as an excuse to lower your grades. Medical school is very competitive, very competitive. I don't know, I mean, it's been a while since I first applied, so I don't know if things have changed, but you always want to have top grades. You know, some B's are okay. I would say some C's, try to like bypass that. But grades are important going into medical school. for residency, or I'm sorry, once you're in medical school, you're going to see, and it was my experience, you know, in pre-med, you're so used to having good grades and being top of your class and you're doing so great. And then you go into medical school and you're like, oh my God, I'm stupid because these people are getting straight A's and I'm here struggling to get a C passing. So the dynamics change a little bit. But in medical school, once you're in medical school, you really need to not try to fail. Grades are really important going into applying to medical school, but once you're in medical school, it's not that crazy.
Great, thank you so much. There's been a lot of talk about that in the chat today, so thank you for helping us out. So I think we'll end on one last question that I know a lot of people always like to hear is, you know, as we've talked about, we're hopefully ending the pandemic soon, fall, spring, or yeah, if everyone can get the vaccine. But as we still have a few more months on our end, and we're still, you know, lacking opportunities and the ability to go in person, do you have any special advice for us as pre-med students during this time?
Well, so the format that you guys have set up, I think, is a great idea. I've never heard of it before, so I'm glad that you guys, you know, we connected. I believe going through these little platforms is great because you get exposure to different fields, stuff that you probably wouldn't normally be exposed to at all, even as a pre-med, but you have actual doctors, residents talking to you, so you get an idea of what you like or definitely don't like. And even with the COVID, I would say try to reach out to people. Maybe they won't let you shadow them now, but maybe in the coming months they will. Always reach out to people. I don't think it's going to hurt. You know, what did they do? Say yes, and you can go. Obviously, be careful with, you know, use your mask and you have the proper PPE. But I would say just don't let it discourage you. Always try to push forward. Be pushy if you need to, and ask doctors, ask them if you could shadow them. Even if they're in the office and they're doing telehealth, at least you can see it through chat. Sorry, guys. So just always reach out.
Yeah, that's definitely true of everything. So never, you know, be discouraged and do your best to just network and find anyone, ask anyone questions. So thank you so much for giving your time today and answering everyone's questions. And I know what dogs are like, so I understand your pain right there. But we appreciate you being here and answering everyone's questions very openly and truthfully. So that was awesome. There's so many people in the chat saying thank you and they appreciated it, and your willingness to give advice.
Of course, thank you guys so much for having me. It was a pleasure. And like I said, if you guys have any questions or on aesthetics or just anything in general, I had my Instagram handle there for the business, but you can always find me personally